Good morning. My name is Adam Rubenfire, and I'll be moderating today's Modern Healthcare webinar, Improving the Performance of Employed Providers. The current reimbursement environment is forcing hospital administrators to closely evaluate provider performance and productivity along with program performance. So much so, they're re-examining insourcing versus outsourcing, cost effectiveness, revenue growth, and overall patient satisfaction. How do you know if your current model is performing optimally? This webinar will focus on fundamental concerns and challenges facing emergency medicine and hospital medicine programs with hospital-employed providers and best practices to maximize performance. We'd like to thank SCP Health for sponsoring today's webinar. At its core, SCP Health works to bring hospitals and healers together in the pursuit of clinical effectiveness. With a portfolio of over 8 million patients, 7,500 providers, 30 states, and 400 healthcare facilities, SCP Health is a leader in clinical practice management spanning the entire continuum of care, including emergency medicine, hospital medicine, wellness, telemedicine, intensive care, and ambulatory care. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for you, our audience. You're encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. You can resize the webinar window by grabbing the corner of the screen with your mouse. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. Now, I'd like to introduce our speakers for today's webinar. Lisa Fry is SCP Health's Chief Growth Officer. She is a seasoned healthcare executive with over 25 years of leadership experience in supporting clients and companies to grow profitable revenue and improve business operations. With a wide variety of experience in different operating structures, including partnership LLP models, not-for-profit, publicly traded, and privately held companies, as well as startup and financial turnaround situations, she's leading SCP's new top-line revenue growth. Chris Lutes is Executive Vice President and Group Operating Officer at SCP Health and brings 31 years of experience in management, operations, business development, and leadership to this role. Lutes is responsible for successful operation to include, but not limited to, delivering quality service and results for hospital, physician, provider, and organizational partners. And finally, Dr. Scott Ellner serves as Group President for Physician Alignment at Centura Health, providing leadership to Centura Health Physician Group, Colorado Health Neighborhoods, a network of 3,600 physicians in Colorado and Western Kansas. Prior to serving in this role, Dr. Ellner served as the CEO of Centura Health Physician Group, supporting the multi-specialty group in providing whole person care and building flourishing communities. And with that, I'll hand it off to our speakers for today. Lisa, the floor is yours.
Terrific. Thank you so much, Adam. Thank you all for joining us today, and thanks to Modern Healthcare for hosting today's webinar. We're really pleased to have the opportunity to talk with you all today about this topic, which many of you probably recognize if you've been around in healthcare for as long as it sounds like the three of us have. This really has been a challenge for a long time, but to varying degrees for hospitals, really thinking about how to optimize the performance of employed physician groups and practices. But since physician employment by health systems is on such a significant upswing over the past several years, we see this now as a topic of growing importance to address in order to ensure the long-term financial health and success of health systems across the country. So today we'll review some of the foundational fundamentals to addressing the performance of your employed provider practices, and then we're going to suggest some updated approaches to this challenge, which now really faces a growing number of hospital and health system executives. So the outline of our presentation today will begin with a brief overview of the end goal in mind. How do we define optimizing that investment in employed practices? And then we'll discuss really defining what some key performance indicators or key performance metrics are that we would suggest we focus on. My colleague, Chris Lutes, will focus on the 3 critical success factors that we think really contribute to the optimal performance of those key indicators. And then Dr. Ellner is going to focus on how this all comes together in practice with a real-life case example from Centura Health. So let's talk a little bit about the keeping the end goal in mind. So as hospital executives have embraced growth initiatives to drive overall success, Building strong physician alignment and strategic alignment with those physicians across a wide variety of specialties continues to be a critical component of growth strategies in general. And in fact, we've seen tremendous growth in employment of physicians in the last 6 years alone, over 18% growth, or really almost 75% if you really look at that as a percentage change. And then that combined with just the other trends that we see, like the preference of younger physicians in the market for employment models versus independent practice, has worked in conjunction with hospitals' strategies and really contributed to this growth rate. So for those of us who've been in healthcare for a number of years, we certainly recognize that this challenge has been around for a while, but I really believe that now the degree of importance around addressing this concern is now magnified, given some of these numbers that we're seeing. And the real challenge, just to put a little bit of numerical definition to it, is that consistent financial, quote-unquote, drag, if you will, on earnings from the health system that come from employed practices. And if you look at the research and the information that's out there in the market, we typically see on average roughly $250,000 a year per provider or per physician in particular, that the health system either loses or subsidizes in terms of the cost of that practice. Now, nonetheless, even given that, there's a wide variety of excellent strategic reasons to make this investment. So we're not here today to question that investment. It's absolutely the right thing to do for many, many reasons. But our goal today is really just to suggest some initiatives that can help optimize your investment in that physician employment model through effective performance management. So what are a couple of those just specific challenges in terms of optimal performance? So some of these that we see as we, common themes as we work with hospitals in optimizing these programs. And the first is that every specialty, medical specialty in particular, is very unique. And it has very specific dynamics and opportunities for things to go well and for things to not really go well at all, and to go poorly. And so that management drain puts a lot of burden on the executive team of a health system to manage individual specialties, because there really are different flavors of things that you need to do if you're managing radiology, for example, versus hospital medicine versus a primary care practice, for example. The other things that we find are, number one, first and foremost, often hospitals don't have great systems and measurement tools to measure physician practice-specific metrics. So they've designed measurement tools that certainly help with an inpatient environment or an integrated delivery system in total, but physician-specific metrics are typically different. Then we also look a little bit at alignment. And sometimes, while we're all incredibly focused on staying within the guardrails that were provided from a regulatory perspective around compensation and things like that, it's sometimes difficult to strike that right balance between the compensation and alignment goals that you have with those employed practices and then the regulatory constraints that you have to work within. Next, from a revenue cycle expertise, we often see some challenges there as well, as professional fee coding and billing is a very different animal from facility revenue cycle needs. And it sometimes is a lower priority, frankly, for the finance team within a health system, because the facility revenue is so much larger in terms of order of magnitude than the professional fee coding and billing. So if you were going to have to really prioritize your resources, that would be a logical choice to make. So that's a challenge that we sometimes see. And then just lastly, we see challenges just around the fact that the business economics and the dynamics of running a physician practice are often quite different from the larger scalable economics of an integrated delivery system in a health system. So I think this is a good point to pause here and learn a little bit more about our participants' specific challenges. And so, Adam, we are ready for our first polling question.
Well, wonderful, Lisa. I'm happy to launch that first poll. So I will put that on the screen right now. Audience, our first poll is, relative to your employed hospital-based physician practices, which of these factors keep you up at night? Provider recruiting and retention, consistency of clinical outcomes and documentation, increasing provider satisfaction and productivity, improving the patient experience, or cost effectiveness of the practice. And you can select all that apply. And we'll just give you about a minute to answer those questions, and then our panel will discuss. Okay, audience, about 10 seconds left. So if you haven't made a poll choice yet, please do, because we will be closing in just a few seconds. Okay. And there are our poll results, Lisa.
Okay, great. All right, so it looks like we're pretty closely tied, but it looks like increasing provider satisfaction and productivity is the leading concern, along with cost effectiveness of the practice as a very close second. So those certainly go hand in hand in terms of that. And I definitely think that part of provider satisfaction and productivity is really about setting clear expectations and providing, again, specialty-specific tools and resources and training to really support your physicians in meeting those goals. So let's dive into a little bit more about that and how we can be clear about defining what that desired performance really looks like. So the first very basic step in improving performance is being clear and articulating what success really looks like. And there's so many key stakeholders within the health system organization, and those stakeholders, as many of you probably know, often differ in their opinions of what success really looks like. So we believe that first and foremost, you want to think about how your success in the practice, in whatever employed practice you're really thinking about, how that aligns with the health system's overall goals. And really a way to think about that is, what was your original investment thesis or strategy associated when you made the decision originally to employ provider practices? So certainly you made an internal business case about that and made that decision, and so that's always a good starting point, a good place to start in terms of thinking through those goals. But we often find that the definition of success really fall into three primary categories. The first is really thinking about the overall performance of individual providers as it relates to variations in practice patterns and things like that, and we'll talk about that in a moment. Secondly, we see the question the survey folks responded to the highest, which is really a question of productivity, and then lastly, program performance. So that's really thinking about overall patient satisfaction and the quality and outcomes of the program overall, whatever that practice may be. So from a provider performance perspective, we think about that in a couple of different ways. You first want to think about, as I mentioned, clinical variation and ensuring that the providers in the practice are all practicing consistently. So really thinking about having enough specialty-specific expertise to know what metrics are most important to measure and what the appropriate targets are for each measure. I mean, I'm sure we've all seen, we get large edicts from CMS and from commercial payers saying that we should be tracking all of these different metrics, and if you add them all up and create a document that has them all listed in one and capture everybody's, there's probably tens if not hundreds of them. And so really rooting through that list and narrowing down to the metrics that truly need to be consistent, and then really deciding on the appropriate targets for each of those metrics is important, and certainly is specialty specific. You also want to have a process, obviously, to think about evidence-based practices, making sure that you've got a culture in place and a quality committee structure that can establish these and then ensure that they're followed, again, at a practice-specific level. And then lastly, from a provider performance perspective, we think a lot about clinical documentation. And it's critical to engage in ongoing and continuous provider training about clinical documentation. It is not a one and done type of work process there. And then give providers as near as possible to real-time feedback in terms of their specific charts. So if they have gaps in their documentation, really be thinking about that. And this graphic is just an example of some of the feedback that we provide to our providers. This is an emergency medicine example, but you might look at length of stay, some operational throughput metrics. We look at quality scores and outcome scores, and then also resource utilization metrics, and try to give that feedback to the physicians in an unblinded way where they can see how they compare to their colleagues within their practice. So the second piece is productivity, and again, that was an area of interest for a lot of the participants on the call today, so I appreciate that. And we really find that, one of the things is that you've got to focus on, in order to maximize the value that you're getting from these incredibly high value, highly talented people on your team, you really need to think about appropriate metrics for measuring productivity. And what we found in our experience is that you can't just pick one metric because you may then end up with unintended consequences. So for example, if you track just total RVU production, for example, by a particular individual provider, you may end up with unintended consequences of chasing of RVUs and things like that. And so you want to also look at a mix of things like, what is your average RVU per encounter, for example, or, which might get you at a little bit more information about documentation and the level of acuity that your providers are seeing. You might want to think about the total provider or practice cost per RVU delivered. So how much is it costing me to deliver this set of production? And that really then allows you to be a little bit more forward thinking as well about the mix of professional resources that you're using so that you can be as efficient as possible and really incorporate in things like the use of NPs and PAs as well. So then from the third metrics perspective, from a program performance perspective, there are a lot of different metrics that you can choose, but I think that one of the things you want to take into consideration here as well is picking metrics, some of which, and finding a balance between some metrics which are specialty specific and can be directly impacted really almost on a one-on-one basis by those providers in the practice, and then some metrics that are multidisciplinary or interdepartmental metrics. So a metric from a quality perspective like sepsis, for example, would be an example of really takes a village to create great performance in terms of that, and thinking about how all the different departments within the hospital and teams perform and come together to really deliver on those protocols and those results, versus something that's more of an operational throughput type metric, like let's say in the emergency department, your door to provider time, where you really do need to focus a little bit on the actual speed at which your providers are seeing patients and how that flow process is working. And then lastly, from a throughput perspective, even carrying that through though from the ED, is once that patient is seen and the decision's made, for example, to admit a patient, then again the whole team really comes into play from housekeeping and environmental services, making rooms available, beds available to new admissions, to the transport teams and the hospitalist teams themselves. So you've got a lot going on in those, but I think a good mix between specialty specific or individual contributor specific goals versus interdisciplinary team goals are really important. So now we're going to switch gears a little bit, and that covers a little bit about some thoughts for all of you on how we think through the definition of success and some of the key metrics and performance indicators that we suggest you think about on a specialty-specific basis or a practice-specific basis. And now I'm going to turn it over to my colleague, Chris Lutes, and he's going to introduce you to 3 critical success factors we really consider as we work toward practice improvement targets.
Thank you very much, Lisa. Hello, everyone. It is great to be with all of you today. Let's take a few minutes to review critical factors for maximum performance in order to provide fundamental strategies that allow us to successfully impact provider performance, productivity, and program performance. We do indeed outline the 3 principal critical success factors for maximum performance as follows: leadership communication, financial alignment, and reporting and practice management tools. So for each, we will review best practices and common pitfalls, what to do, what not to do.
Now we're ready for our polling question.
Wonderful.
Now we're ready for it.
Well, I'm happy to launch that second poll for you. Audience, our second poll is, what critical success factor is the biggest struggle for your employed practices? That might be leadership communication. It might be financial alignment. It could be reporting and practice management tools. If you could choose the one that is the most critical success factor for you, your biggest struggle, that would be great. We'll give you about a minute to answer this question, and we'll let you know once we get the results. All right, audience, we're getting to about 10 seconds left. So if you haven't made a choice yet, please do, because we'll close the poll in just a few seconds. Okay. No surprise here. Money is always a top priority.
So yes, this is Chris Lutes again. Interesting and instructive result to the polling question. I think our polling participants, as was just stated, are certainly in good company, as many programs across our healthcare landscape, our hospital group landscape, clearly note this as a major opportunity to do better and to focus on. So let's take a few minutes and talk about leadership communication, our first critical success factor. Without communication, we will simply not have effective leadership. Without leadership, communication will be rendered ineffective and underwhelming. Leadership communication best practices, what we should do to attain our collective goal and our mandate of maximum performance. Select and invest in the right leader, building a culture. Your physician practice will be hard-pressed to establish the best culture without the right and properly supported leader. Recruit with intention for your leaders and for all providers. Invest in this process and onboard with a structure that encourages, is optimistic, and establishes accountability at the outset. Establish expectations and confirm you have done so. Reinforce expectations in the immediate and ongoing. Redundancy with peer group examples of desired behavior, useful activity, successful peer results all facilitate buy-in and belief. Address underperformance. It is simply a clear and honest way to demonstrate you care. You believe in your investment and you will nurture such. Be active. Participate in working committees. It is how we learn, create credible platforms and constituencies that develop support and the cooperation necessary for change, which in turn leads to improvement. Manage by walking around. Walk through doorways. Be seen. Communicate often. Establish formal communication cadence and adhere to it. Do not deviate. Then, as we implement change and perhaps disrupt, the communication structures and platforms are understood and in place. To communicate only when in crisis, or to correct a mistake, or to ask for something, that is a failing strategy. Also, recognize and teach the importance of informal communication. So what should we watch for with leadership communication best practices? Management barriers always exist. They're often unintentional. They're connected to a knowledge base, an experience, behavior that has in fact previously been positively reinforced and thus becomes habit. So we mitigate this by cascading and communicating our message. Most leaders are more than capable of having a crucial conversation. Many leaders choose not to. This is an endeavor that improves with practice, so do it. Practice. Leaders must have crucial conversations sooner rather than later. It is one non-negotiable element in how we optimize and help others. It is essential to educate managers, key function operators, and teams what the downstream impact is of their actions or inactions. This exercise will serve to break down silos, expand awareness of how actions impact performance. Compel your people to meet, to talk, to find common ground, to follow up, to move the needle on one issue, declare victory, and do so again. So let's talk about our second critical factor for maximum performance, financial alignment. What should we embrace? Creating a basic incentive alignment is a necessity, easier said than done. It requires an internal effort that includes marketing in your own house, listening, follow-up, and message discipline. Inside-out ownership yields best and sustainable results. We must identify, know, and win key provider influencers to endorse and carry our message. To do so requires us to enact some of the influencers' ideas, which in turn delivers a W to the provider group, which builds trust and facilitates progress and allows us to attain our big picture program objectives. Base salary, productivity, quality, and citizenship. Know and understand your local market to establish base compensation. That moves quality providers in the door. Productivity connects to system or group standards supported by national benchmarks, also highly impacted by the local regional market in which you must be competitive. Quality is simply required and measured by your clinical leadership. Culture, conduct, citizenship, how we treat others, and what you want for your program's culture. Compensation plans must be easy to understand. At first, our goals are base hits, singles, doubles, not home runs. We can aim for the stars at a later date. Now, we establish the credibility of the plan, we create affirmative experience, we pick off low-hanging fruit, we exit extreme outliers, all the while building a sturdy foundation from which to elevate. Finally, be certain of your ability to administrate the plan and meet deadlines. Count on challenges and challenging queries. People, processes, systems, and data all need to be tested, retested with trial efforts. An error remediation plan should be well established in advance of a go-live date. It too tested, as errors are inevitable. Again, it must be easy to administrate, which will translate as easy to understand, which indeed will yield better results. So what should we watch for with financial alignment? The balance of the carrot and stick. Create early wins and also hold abject non-performers accountable with unassailable data. Be accurate. Accuracy is a requirement. Transparency is accurate data at the right time. Set thresholds that ensure the compensation plan will fund itself. Test it and retest it. Understand barriers. If you imagine a barrier, act upon it because your instincts are likely correct. Obstacles will live within people, process, and technology. Know the provider or influencer who others in the group listen to. That's often the medical director, but it's also often another vocal or well-established provider. Seek them out early. Win advocacy. So our third critical factor for maximum performance, reporting and practice management tools. Let's talk about what to do. Use technology and use it with a precise purpose. The technology tool is rarely a panacea. Ease of use, meeting deadlines, particularly pay milestone timelines, adapting your technology tool to your program, all essential in order to attain the intended benefits. Adjust your staffing model. More, less, up, down, by day of week, by time of year. Agility is a must. Reporting on mundane subjects such as contracted hours versus actual hours worked is a frequent opportunity to optimize. So report, educate, report again, coach. and deputize peer mentors. Use your leaders. So what to watch for with reporting and practice management tools? Data drag, data delays. Late data is easier to mistrust for providers. Remember, our starting point with practice management data is it always feels late to the provider. Poor data, data that erodes trust or reinforces an already existing or perceived credibility gap, and anticipate and minimize variances. Be prepared and prepare groups for potential variances. Be prepared and know that you can minimize the impact through simple plans that also will address your big ticket items. Know your priorities. So our discussion leads us all to do it yourself or look for help, to review the possibility and potential of expanded revenue opportunities, greater cost efficiencies, improved clinical performance, and reduced administrative burden, and the efficacy of considering subject matter experts to support your efforts. Please welcome Dr. Scott Ellner.
Well, thank you, Chris, and I very much appreciate the partnership that Centura Health and SCP Health have been able to put practice into a principle in how our employed providers have improved substantially over the last couple of years. Centura Health is a moderate-sized health system located in Colorado and western Kansas with 17 hospitals, over 900 providers in our employed enterprise, with over 200 clinic locations across a significant geography. And in order to create a unified practice in which there's cohesion amongst our physicians, we realized early on in 2018 that we could appreciate some support. And so we engaged SCP Health at the time, and they did an assessment for us. Fortuitously, this was during the same time that we were drafting our strategic plan for the next 7 years called Centura 2025, which would meet us into some aspirational metrics for that time frame. Now, like many large health systems, we grew substantially. We grew to the point where we had significant physician practices that created some inconsistency, and the level of expectation was very different for many of our multi-specialty practices, whether they were primary care or specialty care. And so the ability to create a unified culture among our employed enterprise really required some thoughtful intervention. It required leadership, an intense focus on quality and the patient experience. We had to align our physicians with organizational goals and make sure that key stakeholders were aware of new and different processes that we were instituting across the enterprise. And then first and foremost, we needed data. We needed key performance indicators which would help us to track our performance and ensure that we were continually improving in order to meet the needs of our health system. Today, Centura Health is a $3.6 billion health system with an employed enterprise that has about $285 million in revenue. And we believe that investing in our employed providers is critical. Now, understanding based on the polling questions, if you are going to grow substantially with your physician enterprise, that is an investment. And we look at when we bring on a physician group or an individual physician, we are going to invest our time, energy, in helping that physician succeed. And so when SCP Health came to us with some actionable data where we identified processes that could be improved, we targeted some very specific service line, notably our hospitalist medicine program, which we had close to 100 providers and needed to create some consistency and some leadership in that program. So that was a great compliment to helping us succeed in that area. So I talked about our strategic framework, which was developed. And we call these physician-facing aspirations. And you can see that the aspirations are built on 5 areas. Notably, the highlighted area is what we call a physician-facing philosophy. And I'll go into what that means in a second. But the idea is that physician-facing metrics focus on the engagement of the physician and their teams. How well are they aligning to the goals of the organization? We look at productivity and setting expectations around productivity, notably whether you're a specialist in a low volume rural area, what are our expectations there versus a family medicine practitioner in an urban area, and what would the expectations be there as well. And then, of course, the EBITDA per physician FTE, or the investment. And that's the focus for our aspirational targets that I'd like to discuss, and how we saw improvements over the last couple of years. So this term physician-facing, what is it? It's unique, and I will say it's not physician-centric, and it's not physician only where the physician is getting everything they want. It is more than that. And the definition we use around physician-facing is an enduring relationship between the health system and our physician partners, in where there is mutual trust, there is respect, open dialogue with bidirectional feedback on things like operational issues involving them in strategy, and of course, meeting the goals of high quality, excellent patient outcomes. And so, in a nutshell, that means we need to make things easy. We need to be sure that we're timely and responsive. We have to create a deeper, more meaningful relationship with our physicians and understand who they are as people, more than just providers who show up to work every day and generate RVUs or revenue for our health system. And then first and foremost, they're at the table and they're actually participating in important decisions which will shape the future of the health system. So when we brought in SCP Health, there was significant discussion amongst our physician peers, including our emergency medicine group, our hospitalist medicine group, which was already employed, that we were going to bring in this partnership in order to help manage our services more appropriately than how we were doing it today, based on the assessment that was done a year prior. And the expectations were that SCP was going to be a partner, but not a vendor or an outside consultant. And we have seen tremendous buy-in, particularly because SCP has provided medical director leadership and support amongst our physicians in order to help them be more successful in the work that they do today. The other aspect about physician-facing is that when you consider the relationship, the best analogy I can really think of is marriage. Now, when you're with your significant other or spouse, they don't always get everything they need. Well, maybe with Chris that's the case, but in good times and in difficult times, you have to work through things collaboratively in order to meet certain goals, both for the physicians and the organization. And that's the way that we framed it in order to meet our current aspirational metrics. So here's an example of productivity improvements. Now, when I started in FY16, we were fairly low in our productivity, and we were on a work RVU percentage model where the physicians were paid either on a guaranteed salary or on a productivity target. As you can see, over the last couple of years, we've substantially and steadily increased, and at the same time, we're bringing on new providers. So at the top there, these are aspirational targets. So you can see for our FY20 budget, which is coming up, our goal is to hit 46th percentile of productivity. And that continues on up until 2025 to about 52 percentile. Well, you may ask, well, why isn't it 70? Why isn't it 90? And again, this is the entire multi-specialty group. Now, some of our family medicine or internal medicine physicians are in the 90th and they're performing really well. But we also want to incentivize them on their panels and making sure that they're meeting high quality standards. And some of them are very high producers. Some of them are moderate producers. They're around the 50th percentile. And some of our service lines, particularly in a rural location where we have offices in Kansas, we don't expect them to be above the 35th percentile because the demand just isn't there. So this is a reasonable and actionable target that meets our aspirational goals around productivity under physician facing. And this target was brought forth by the physicians. And so we agree that this is something that's rational we can work for in the future. So the next slide shows what many of you are talking about today, that investment per physician. And so this has been a very difficult challenge when you are investing. There's a significant cost that goes into a practice. And as you can see in FY17, our investment per physician for a multi-specialty group was very high. And as Lisa had noted early on, the average is somewhere around $250,000. So $350,000 per physician was out of the current benchmark. It was an outlier. And so we needed to make some significant challenges around operational efficiencies. Now, the idea here was not to do this on the backs of the physicians. The idea was to look at what are some of the non-provider expenses, what are some of the areas where we can be much more efficient in order to decrease that overall investment. How can we raise revenue to be more productive? And so as you can see over time, we're going to finish FY19 around $239,000 this year. And for our targets moving forward up to 2025, we have a goal of reducing that investment in half by 2022 to $142,000. And that is all in. That's orthopedic physicians, that's anesthesia, that's hospitalist medicine, including primary care, which we feel that with our current trajectory and the things that we are doing, not only to engage our physicians to be involved in improving the investment, we're going to hit this target. The next area I talked about is the non-physician expense. Now, many of our physicians are paid on a WRVU standard. And we identified that one of the largest costs wasn't necessarily the compensation toward the physician. Physicians should be paid appropriately to what they deserve. And in a competitive environment like many of you are in, it's a challenge to keep physicians and to pay them respectfully what they deserve. So in order to focus on reducing the overall investment, we looked at what are some of the non-physician expenses that we could address in order to bring down that investment. And so there were tremendous areas such as looking at leases, looking at consolidation of practices. How did we work better with our MAs to support the administrative burden for the physicians? Was a nurse more appropriate in one environment versus maybe an LPN? And so staffing ratios, position control, looking at our supplies, all of those were taken into account. And as you can see over time from FY16 to our budget, which will be released for FY20, we've decreased substantially from $119 per work RVU down to $90 per work RVU, which for the first time, that is now covering the physician's salary. So we were upside down in that our expenses were actually overshadowing the revenue that was being generated by those encounters. So a lot of work gone in there. And now I'd like to go into some detail about what SCP Health has done specifically around our hospitalist medicine program. As I mentioned, in roughly 15 hospitals of our 17, we have a hospitalist medicine program. We had several hospitalists, many of them younger generation, who are coming out of residency within the last 5 to 10 years. And we had an issue around locums. We just could not support a consistent level of staffing for our hospitalist medicine program. And so what that does is it decreases morale, it creates inconsistency and variation. And so the first thing that SCP did was put in some guardrails, and they were able to reduce our locum spend on our hospitalist medicine program by 70%, translated into a $2.4 million savings for us. So that was a great opportunity. And how did they do that? Well, first and foremost, they worked with the physicians peer-to-peer. Rob Michelson, who is the medical director for our program, was there on site management by walking around, setting expectations. He was instrumental in helping us to craft a program in each of our hospitals that created consistency and expectations. Some of the other areas that were identified, which substantially improved, and I will tell you the physicians really appreciate this, is working on documentation. And what we found is a willingness for the SCP team to sit down and identify through chart assessment, full chart assessment, any clinical documentation deficiencies that were identified. And roughly 80% of those deficiencies were addressed in the first 5 months. And so today, a majority of the claims that are now going out in our program are, I would say, close to 99% clean, which has a huge impact on our revenue cycle indicators. The other area was looking at our hospital case mix index, which early on our range was much lower, and that's bumped up to between 1.6 and 1.7. We're seeing that many of the cases were either undercoded, or some of those cases weren't treated appropriately as maybe critical care. And so the case mix index has substantially improved with the guidelines and the support and the expectations set forth by SCP as a partner in our management team. Other opportunities were the professional collections. Now, there are some specific numbers about our work RVUs that we saw. Our encounters were fairly low compared to national benchmarks. And so with the support and the attention to detail that SCP put forth, and really looking at how to craft the note in a much more meaningful way, we saw an increase in about 10% in our overall collection fees for our work RVUs per encounter. So a lot of really great work in the operating improvements. Staffing ratios are meeting the goals, where we're seeing an improvement in the number of patients who are being seen per day. Patient satisfaction continues to do incredibly well upon our HCAHPS scores. And overall, our Net Promoter Score has seen an improvement based on whether or not our patients have a likelihood to recommend our health system. And that meaningful change is the impact that SCP Health has provided in supporting our hospitalist medicine program. Now, physician engagement is a key area where none of this would have been possible if we didn't have the attention from the medical directors from SCP Health and the medical directors at Centura Health who were focused on our service lines. Now, these are actual physicians who work at Centura Health. All of our marketing, anything that goes out to the public, focuses on our physicians. No stock photos. And the reason why is because we're very proud of our incredible physicians and the demonstrated leadership that they show and the willingness to do what's right on behalf of the patient. And over the last couple of years, our physician engagement score has gone up drastically, where transparently, it wasn't like it was. And in some of the hospital-based health systems, it was around the 21st percentile. And in late 2018, we've gone up just below the 50th percentile in engagement. And That's a substantial improvement for us because we know that physicians are feeling like they're being involved early, often, and frequently in key decision making. So that's been an important opportunity, and SCP Health really focuses on things like leadership, how to improve the overall dynamic between the teams, the hospitalist medicine teams, and those leaders. And what that has done is created an environment of trust. So it's not, as many of you know, it's not easy, and it requires a presence. We had to make some changes. Some of the leadership that we identified early on may not have been the right leadership that we have put in place today on the Centura Health side. And with the demonstrated support from Chris Lutes and his team and the physicians from SCP Health, we have developed a strong leadership and mentor program, which has allowed for greater peer-to-peer communication. The trust is now there where if different opportunities around access and how we manage patients, whether it's through staffing or management of the census, when those are being instituted, there's now more of an enthusiasm to work collaboratively than what we have seen before. And that goes back to being transparent around how we communicate and receive bidirectional feedback. What's critical is that you establish a governance structure. And from the highest level, myself and Chris Lutes and Dr. Derek King from SCP Health, we meet quarterly to discuss any key issues that may arise, whether it's impacting our physicians or whether there's a patient outcome. And that information is cascaded down to the medical directors of our regions and then down to the site leads, where that information is ensured that it gets to the people on the front line. So they're all understanding what's happening, and there's no surprises when they come in to work for that day. We want them to feel like they have a consistent work environment where they're being supported. Now, there's going to be bumps in the road. There always are. But I will tell you that in just a short amount of time, this relationship with SCP Health has been one of the most important areas that has impacted the success of our strategic plan moving forward. So, you know, I would tell you as a testimonial, as a physician myself, working with a vendor more as a partner and bringing them into the environment where they get to know our physicians, nurses, and other stakeholders is key, so that the visibility is there and the trust is developed, and you will see your success will improve both with operating, financial, and revenue cycle indicators, and of course, patient outcomes. So now I'm going to turn it over to Lisa.
Thank you. Thanks so much for that. So just to wrap up, we hope that today you found today's discussion helpful, you know, really focusing on how you can create optimal performance supported through the things that we've talked about today in terms of leadership and communication and that alignment and the tools that are important for that. And so I couldn't agree more with you, Dr. Ellner. At the end of the day, we strongly believe that a clinical partnership who really works with the hospital to understand your goals and then the needs and the needs of your patients and your community can really be a powerful ally, I think, when aligned with your local leadership and capabilities. And hopefully that all comes together and creates optimal performance for this important investment in resources that many hospitals across the country are making. So thanks so much for joining us all today. And Adam, I think we're ready to take some questions if we have a few minutes still.
Well, fantastic. Thank you for that phenomenal presentation. We'll launch into a brief Q&A. Audience, if you have questions, continue to send them in. Even if we do not, if we're not able to get to your question today, the experts from SCP Health will be more than happy to follow up if they're able to answer your question. So we'll start with our first question for Chris. Chris, what is the specific mix currently used for physician compensation between base salary and incentive amounts?
Thank you. It's a great question, and it's one that a whole lot of folks have struggled with over a long period of time. The mixed percentage between base salary and incentive compensation should include a minimum 25% in incentive pay. This component incentive percentage will align the provider group with your priorities, and it also conveys the importance, the gravitas of your compensation plan strategy.
Fantastic. And the next question we have is about measurement, how you measure clinical performance at the physician level. Lisa, I'll ask you this, and if anybody else wants to chime in, how do you measure clinical performance at the individual physician level?
Well, thanks, Adam. I mean, it's very specific to the specialty. So I think, again, as we mentioned earlier, you really want to think about what the right, sort of weeding through the noise of all the metrics that our industry puts on us, and thinking about those clinical, operational, and then resource utilization metrics that are important for that specific specialty. So that's, I think, where it comes in helpful to have a partner that specializes in a certain specialty, so that you can understand really what metrics move the dial and which ones are sort of more of a nice to have type of thing. And Dr. Ellner, is there anything you would add?
Yeah, and I would add that providing the information on performance real time, if you can, is critical, so that the physician gets feedback right away. They understand how they're performing, whether it's the number of encounters they're seeing or their patient satisfaction score. The metrics have to be aligned with the metrics of the health system. And so if they're meaningful to the outcomes of the patient, and they're also driving down costs, which we know is also really important today in healthcare, then those are the metrics that we put in place.
Great. And Dr. Ellner, the next question we're getting is for you, really about clinician alignment and buy-in. Kind of a two-part question here. The first question really is about buy-in. One of our audience members says they tend to have difficulty in getting physicians to buy in when they implement new processes. So they're asking, how do you balance provider satisfaction and buy-in while still achieving financial success? And on that same note, if I could just ask one more question along with that, did most providers stay with your group after you brought in a practice management partner?
So buy-in is the challenge that I think all of us face every time we're trying to put an initiative forward. And first and foremost is bring in the physician influencers, and some of them are positive and some of them are your biggest naysayers. Bring them in early, and also the approach that I work with many of the physicians in order to get buy-in is to first listen, to understand what are the pain points that they're feeling in their practice from an operational standpoint. What can we do to make this easier? And if I can do it, I will follow up and I will do it. If I can't do it, I'm not going to give the slow no. I'm going to say, you know what, at this time, we can't get you that piece of equipment, but I hear you, I hear you, and if we can work it out over time, we will certainly try to accommodate your request. I think there needs to be full transparency in what the organization is trying to accomplish, and involving the physicians in those decisions really helps with buy-in. Now, there's always going to be a small percentage who will continually try to resist and won't want to change. But for the most part, you've got to focus on your influencers who are able to get their peers to also go along for the ride. The second thing is retention. And it was, I would say it was fairly concerning initially when we went with an outside management practice program to look at some of our service lines, because many of the providers felt like, well, they were going to be at risk, they were going to be, say, bought up or sold off, or the worst part was they felt like maybe they were being owned, and that's not the case. We treat our providers in a way where they're partners. We never say we own them, even if they're employed. And so we involved them early on about this partnership with SCP Health, and our attrition rate was very small. It was less than 5%. And so, in fact, we grew substantially and brought on 2 more hospitals when SCP Health came on board, because they were really putting best practices in place. So this was a really great opportunity for us to partner, and it's really showing the benefits today.
Fantastic. And we've got just one more question before we conclude today's webinar. It's for Chris. Chris, what sort of governance or regular meeting structures are you using to change the practice performance and culture?
Adam, thank you for that question. You don't know how happy I am to hear that question, because if you aren't intentional about your meeting structure, your meeting cadence, you will not accomplish your goals. None of us will. So some of the factors that influence a meeting structure are really the scope of the healthcare system, the number of hospitals, the number of providers, the number of programs, even geography. In short, you must have a consistent meeting plan. And you heard Dr. Ellner reference Governance Council earlier. In our partnership with Centura, we have site lead or medical director meetings, steering committee meetings, which occur monthly. The Governance Council meeting is quarterly, as was previously mentioned. And we augment all of those structured meeting forums with also an intentional task force initiative strategy, where we handle priority issues in real time, very quickly, by gathering up the stakeholders and getting something done. And all of this, of course, is governed by intense communication. We communicate frequently and all the time. Thank you.
Fantastic. Well, that takes us to the top of the hour, and it is time to conclude today's presentation. A special thanks to our audience for the great questions, and a thank you to our speakers, Lisa Fry, Chris Lutes, and Dr. Scott Ellner, for a phenomenal presentation. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd like to thank the sponsor of today's webinar, SCP Health. For more information about SCP Health, please visit www.scp-health.com. This webinar will be available on demand, and a copy of the slide deck and a link to a recording will be emailed to you within the next 48 hours. This concludes today's presentation. Have a great day.